Welcome to Module 9 of Mechanical Ventilation Basics, where we will examine managing alarms with the Hamilton T1 during invasive and non-invasive ventilation. Alarms signify changes in patient condition or equipment issues. Mastering alarm priorities and troubleshooting is crucial for ensuring patient safety while maintaining your focus and comfort. The learning goals for this module are navigating the T1 alarm system. The T1 manual includes over 90 alarms with varying priorities, making it impractical to cover all potential solutions in this course. Instead, we will concentrate on equipping you with the essential skills and knowledge to efficiently assess and manage any alarm situation you may encounter. Therefore, our primary aim is to establish a standardized alarm management workflow for crashing and stable patients, focusing on patient safety. For clarity, we will establish clear definitions of the crashing patient and the stable patient with alarms. Since entering service, the T1 has garnered worldwide recognition as a trusted pre-hospital ventilator. Healthcare providers across the globe appreciate its advanced capabilities, although occasional alarms may still arise as part of its operational features. This module will explore typical alarms encountered in our clinical practice. By applying the alarm management workflow presented in this course, you will develop the knowledge and skills to troubleshoot any alarm situation with confidence and accuracy. Please refer to the Troubleshooting Alarms algorithm in the ALS Mechanical Ventilation Policy on Clinical Design as you study this module. After starting mechanical ventilation, you can adjust the alarm settings without interrupting ventilation. There are two simple methods. Touch the Alarms button, located at the bottom right of the display, or tap any main monitoring parameter on the left. Both methods lead to the Alarm Limits window, which displays current monitor values next to each alarm bar. Use the Auto button to quickly set limits based on these values, except for tidal volume and apnea, which require manual adjustment. Close the Alarm Limits window by tapping the X in the upper left corner or the Alarm button in the lower right corner. Alarms are categorized into 3 priority levels: low, medium, and high. The message bar at the top of the ventilator screen employs color-coded banners and audio beeps to indicate these priorities. Red indicates a high-priority alarm that emits 5 beeps, implying immediate action is required. Yellow indicates a medium or low-priority alarm. Medium priority alarms emit 3 beeps, suggesting an action is needed to mitigate the alarm. If multiple alarms occur, messages will alternate in the message bar. If an alarm affects a main monitoring parameter on the left of the screen, its color will change and a colored bar will appear to the right to show the alarm status. Tap the alarm banner to view all active alarms. Select an alarm to see potential solutions. When an active alarm is resolved, it moves to the inactive alarms list and is stored in the alarm buffer. A red eye icon in the media center indicates that information about inactive alarms is available. Tap it to access the inactive alarm buffer, which is arranged with the most recent alarms listed first. Alternatively, press Alarms and choose the Buffer tab to view both active and inactive alarms. selecting any inactive alarm will also display solutions. Press the reset button to clear all alarms from the buffer. A crucial note about strong fundamentals. In medicine, mastering the fundamentals is not only advantageous, but also a critical factor that distinguishes competence from catastrophe. Consistency is key. Verify preoperative checks and circuit connections, and tighten all fittings, including the flow sensor and green high-pressure hose. Remember, preventing issues is invariably more effective than addressing them once they arise. A typical alarm caused by loose or disconnected circuit components may trigger disconnection alarms on the ventilator or patient side. Naturally, flow sensors, adapters, circuits, fittings, hoses, and various connections can loosen and detach at any point. So rechecking periodically when alarms occur is imperative. Imagine you are monitoring a ventilated patient when suddenly alarms of various priorities sound. Lights flash, alarm noises blare, and your head feels ready to explode. Oh my goodness, the horror. Unruffle your feathers, put your coconut back together, and let's figure these alarms out. Step 1. Silence the audio, or mute. The alarm noise can be overwhelming. Press the mute button on the ventilator to silence the alarms. This action will allow you to investigate the cause without distraction. A solid red light next to the mute key indicates that the alarms are muted. In step 2, assess the situation and ask yourself, is my patient crashing or stable? You've just asked the most critical question in alarm management. Promptly seeking an answer to this question, followed by the appropriate response, improves patient outcomes. First, let's define the crashing patient with alarms versus the stable patient with alarms, after which we will detail the remaining workflow steps for both patient types. Defining the crashing patient with alarms. If the patient has increased work of breathing, mental status changes, or is physiologically deteriorating, diminishing oxygen saturation, sudden changes in heart rate and end-tidal CO2, acute hemodynamic collapse, appears newly cyanosed or chest rise is absent, they are a crashing patient. Now let's define a stable patient with alarms. Imagine monitoring a patient on BiPAP when suddenly alarms of various priorities sound. Lights flash, alarm noises blare, and your head feels ready to explode. Oh my goodness, the horror. Of course, you follow the workflow, silencing the alarm audio, and ask yourself a crucial question. Is my patient crashing or stable? Despite the alarms, your assessment shows no changes in skin color, mental status, or breathing effort. The SpO2, end-tidal CO2, heart rate, and hemodynamics remain in the patient's expected range, indicating that the patient is stable. Let's review the alarm management workflow so far. The first step in managing alarms is to silence the audio by pressing the audio pause key on the front of the ventilator. Step 2 asks a crucial question. Is my patient crashing or stable? The answer determines what happens next, and for this, we need a scenario. You finish loading an intubated and chemically paralyzed patient on ASV into the ambulance for transport. You feel good because you secured the intubation despite the patient's prominent overbite. You climb into the patient compartment when suddenly alarms of various priorities sound. Among other warnings for low minute and tidal volume, the most concerning alarm is the disconnection on the patient's side. Lights flash, alarm noises blare, and your head feels ready to explode. Oh my goodness, the horror! Step Step 1, silence the alarm audio. Step 2, ask yourself the most crucial question in alarm management. Is my patient crashing or stable? Along with the barrage of alarms, you notice that the pulse oximetry and end tidal CO2 levels are falling and chest rise is minimal. The patient is indeed crashing. Step 3, if you have a patient crashing on a ventilator, disconnect the ventilator immediately and provide bag mask ventilation using 100% oxygen with PEEP. That's correct. Step 3 of the alarm management workflow emphasizes the need to disconnect the ventilator promptly and perform bagging with 100% oxygen and appropriate PEEP. However, an essential stipulation for initiating bag ventilation immediately is this. If you suspect your patient is crashing due to dynamic hyperinflation, also known as breath stacking, allow several seconds for passive exhalation before resuming positive pressure ventilation. If you have questions about dynamic hyperinflation, review Module 4 of Mechanical Ventilation Basics. In Step 3 of the alarm management workflow, you've disconnected the ventilator and initiated bag ventilation with 100% oxygen and the appropriate PEEP. Ask yourself, is the patient improving? The ventilator or circuit may be the issue if the patient improves with bag ventilation. If the crashing patient does not promptly improve with bag ventilation, we quickly proceed to Step 4 of the alarm management workflow and assess the patient using the DOPES mnemonic. Step 4, DOPES mnemonic. The ventilator alarm signals a disconnection on the patient's side and a low exhaled minute volume. Although the circuit is connected and the endotracheal tube is secured at 22 centimeters at the teeth, you observe an active air leak. Saliva is bubbling from the patient's mouth with each breath, and now you hear a leak. Assessment reveals decreased breath sounds, poor chest rise, and an inadequate end tidal CO2 waveform, suggesting potential tube displacement. However, you know the airway was correctly placed and the tube depth is correct. A quick check of the pilot balloon uncovers the issue. The endotracheal tube cuff is ruptured, likely due to the patient's protruding teeth. To address this, remove the faulty airway, provide mask ventilation to stabilize the patient, and re-intubate. Step 5, continuous reassessment. Ongoing reassessment is critical. The 5th step in the workflow for the crashing patient is continuous reassessment. After the endotracheal tube is carefully replaced, the patient's physiology improves. The end tidal waveform and pulse oximetry return to normal. Once the crashing patient problem is solved, reconnect the mechanical ventilation circuit and closely monitor the patient and ventilator.